The testing is about what percent of those infected are hospitalized to determine the capacity we need in our hospital system. When you look at what happened in Italy, where did they get into trouble? You overwhelm the healthcare system. And that's where you can get into trouble.
Welcome back. That was New York Governor Andrew Cuomo underscoring the importance of testing. Today, the Trump administration tried to assure Americans that the government would be able to meet testing needs. An investigation by The Atlantic found that only roughly 16,000 COVID-19 tests have been performed in the United States as of early March. That would put the United States far behind other developed countries. Dr. Carroll, a pediatrician who writes for the New York Times, explains that tests help medical professionals know how many people are ill. And he warns that, quote, according to some estimates, 10% to 20% of those who are infected may require hospitalization. In a metropolitan setting, if enough people become infected, the numbers who may need significant care will easily overwhelm our capacity to provide it. According to the New York Times, quote, even hospitals in developed countries with the world's best health care risk becoming triage wards, forcing ordinary doctors and nurses to make extraordinary decisions about who may live and who may die. For more, I'm joined by Dr. Anne-Marie Kimball, founder of APEC Emerging Infections Network and professor emeritus at the University of Washington, and Dr. Carroll, professor of Indiana School of Medicine. We just read from some of what he has had to say about this. Dr. Kimball, let me just start with you. How much testing is going to be required? What is the timetable on that testing to get these answers to how fatal this is, what the infection rate is, those basic questions that everybody's asking?
Well, that's a very good question. And in fact, we're well behind the curve on our testing. Let me explain. South Korea should be our model. And South Korea's done 120,000 tests, and they have a population of 51 million people. We have a population of 350 million people. And as you just said, we have about 16,000 tests total that we've done since the beginning of this threat. And what you do testing for is to understand how you do social distancing most efficiently and with the least disruption to people. So we're way behind the curve.
Dr. Carroll, how did this happen? How did it happen that South Korea is able to just get people in and out, do all these tests, and the United States, the number is 16,000 in a country of this many people with this much concern right now?
It's a great question. It appears that we originally turned down the opportunity to take a test that was developed and used by the WHO. Turns out then we might have been slow in accepting some of the tests that universities were actually trying to do. And we've been slow in letting businesses and other companies try to get testing going. And we're just way behind. And of course, lots of people point the blame in different directions, and we might not know for some time exactly where the lesion is, but there's no question there's a big lesion.
What do you make, Dr. Carroll, too, at that press conference today, or at that event at the White House with all the leaders of the federal government's response to this? One point that was made was that some of the data coming back from South Korea, where there is extensive testing, is pointing to a lot of people being tested, a lot of people thinking they have symptoms, having some of the symptoms of it, but proportionally, a lot of them being negative. Is that an encouraging sign that you're seeing it all in the data from South Korea?
I don't know that I'd say it's encouraging. Of course, the more people you test, especially people who have low or no symptoms, the more negatives you're going to get. If you're only testing people who are very sick and are in hospitals, you're likely going to get a much larger number. Until we decide to test almost randomly or, to test huge parts of the population, we'll never have a sense of just the percentage of people in general who are sick. We'll always have a percentage of the people who show certain symptoms. But even then, we just don't know. We're running so few tests that we only know the percentage of people who have really high likelihood of being ill. What percent of them are sick?
Dr. Kimball, one of the things that I'm trying to figure out here is we're entering into this phase where major events are being canceled, social distancing is becoming the norm, folks are being told in a lot of areas to work from home. You're just not seeing a lot of people out there nearly to the degree you did just a couple days ago. The idea is this allows a window for testing. The idea is this will slow as best possible the spread of this. But I'm wondering what happens once that testing is done and once officials have a much better handle on the infection rate and all these questions that are being raised here. Without an effective treatment, And without a vaccine, if we leave this state that we're in right now of shutting so much down, isn't it just going to start spreading like wildfire?
You mean if you open it back up?
Yeah, if we just go back to, holding, kids go back to school, sporting events happen again, concerts are on,
Sure. No, actually, what we're really working for here is probably a limited time of this much social distancing, but we really won't know without the data. So we're all watching for more testing, but more than that, we're watching the curve of cases. And right now, we're in a very vulnerable phase where we could see it go up as fast as it went up in Italy and in Korea, and we're talking weeks. We're not talking a month when we get 5 million tests. We're talking next week. We need to have broad testing and broad access and really understand this epidemic. As we understand it, as we get the data, that's when we can begin to hone our social distancing and say, well, maybe in this neighborhood or maybe in this event, we have the data to say this is actually effective. Over here, we've seen it's not effective. We won't do that anymore. Those are the kinds of choices that public health makes. And that's what we're waiting to do when we get the data. We've got some information from other countries. We know what worked in China. We know what worked in Korea. And we're watching Italy as it unrolls. So we in the United States have the advantage of looking at other people's history and how they dealt with this. And we're trying to put in those social distancing strategies here to see if we can have the same effective clampdown that you've seen in some other economies like Hong Kong, Singapore, et cetera.
Yeah, Dr. Carroll, I'm curious what you make of what you're seeing from some of these countries overseas and some of the statistics coming out of there. Because again, I'm just a layman here, but I read these articles and see these numbers. I look at Italy, and these numbers are terrifying, what you see coming out of there in terms of the number of cases versus the number of deaths, and that rate seems extremely high. You see numbers from South Korea that maybe suggest something not certainly bad, but maybe not quite as bad. What do you make of what you're seeing from these scattered reports around the world?
Well, when you look at a country like Korea, what you're seeing is that if they're testing a ton of people, a very small percentage are actually very, very ill. The much more concerning numbers are out of Italy. That's the cautionary tale, where they've had such an increase of very sick people that it's overwhelmed the hospital systems. There are only so many ventilators. There are only so many respiratory therapists and doctors and beds to go around. And if too many people get sick at the same time, there's just not enough resources to care for them. You have to start turning away people who are there for elective procedures or people who might want to go to the hospital for another reason. And more importantly, you have to start turning away people who need really intensive care for coronavirus because you just don't have it. And then you really have to triage who's going to get care and who's not. That's what we have to worry about.
Well, President Trump was asked if the administration is prepared to provide hospitals with the equipment that they need. This is what he said.
We are in the process, and in some cases have already done it, ordered a large number of respirators just in case. We hope we don't need them, but we've ordered a large number.
Dr. Kimball, when you look at the capacity of America's healthcare system, of hospitals right now, ICUs, how much does that need to be ramped up just sort of proactively?
Well, let me back you up, Joe, just a little bit, because remember that fully 1/3 of Americans don't have easy access to health care. So that's been a big problem. We don't have a situation where anybody in our country can go and see a doctor without having it cost that person a significant amount. So that's the first barrier. And then when you get into, as you know, 20% of the people who have this get seriously ill. So if you estimate that we need about 120,000 beds or so, that's about what we've got. But you could have a lot more getting ill than that. And the scenarios suggest up to 500,000 people who will need hospital beds and or ICU care. There is clearly a mismatch here. Just to let you know, the ratio of beds to population in Korea was 15. Our ratio of beds to population is 2.3, and Italy was about 2.3 as well. So we're more in the Italy camp in terms of our fragility of our health system. And that's why it's even more important for us to understand this epidemic as it plays out in our communities.
And just practically speaking, if the resources, if the will to provide the resources is there, that's what the president is saying. Practically speaking, how long would it take to beef up that capacity to be in a better position than, say, Italy was?
I think you can do it very quickly, actually, with field hospitals and other temporary measures.
Okay. Dr. Carroll, you were going to say?
So I'm going to be a little bit more pessimistic. First of all, hospitals don't stay in business by keeping ICUs and ventilators unused and sitting around. So a lot of them are being used today. It's also flu season, so a lot of them are still being used. It still will take time to build new ventilators, even if we started ramping that up right now. And we still don't know where to send them. And so it would take time, even if we could mobilize a large number and push them to where they needed to be, it would still take time for us to know where exactly the problem spots are. And the capacity to do that and the ability to send them that quickly is not really clear.
All right, Dr. Aaron Carroll, Dr. Anne Marie Kimball, thank you both for joining us. Appreciate it.